Good afternoon, everyone, and welcome to Grand Rounds. My name is Tom Felden. I'm the chair and organizer of Grand Rounds. One of the first people to email me when I ask for volunteers for Grand Rounds is Kevin McConville every year, asking for the regular slot in February, where we, as in Grand Rounds, we help to celebrate LGBTQ plus month, February every year. I was looking at our YouTube channel, and we have a playlist that tags all of the LGBTQ plus talks, and this is the 9th one we've had in the years that I've been curating Grand Rounds. So it's great to have them back again today. We've got a trio of speakers. Kevin's going to introduce things and have a bit of a chat about the Scottish Government Gender Recognition Bill reforms, which I'm sure you will have seen in the press. This has been front page news for a while now. Pascal Scanlan, from his car, it looks like, is going to give us an overview of the barriers and enablers of implementing a shared care agreement regarding gender affirmation. And then Mike, who has spoken at Grand Rounds in this slot before, he's a plastic surgeon, and he spoke before about the barriers in place for what at that time was called gender reassignment surgery, and it's now gender affirmation surgery. And he's going to speak about the changes that have been put into place since he last spoke. I'm going to hand over to Kevin. If you've got any questions or comments, then please do share in the chat. There will be an opportunity at the end to speak, and I do encourage you to do so. I'm going to, at the end, we have a new QR code which you can scan straight from your screen. It allows you to go and log that you were here, and that you get a certificate for your appraisal or your e-portfolio. So I'll show that right at the very end. And thank you very much to everyone for coming. And Kevin, thank you very much once again for stepping up in February to organize this talk.
Thanks, Tom. And I think, not to some, I can't believe it's been 9 years. Actually, we've been doing this, making me feel old in a different way. But thank you always for providing us with that opportunity. And that the original request came of work that the University of Dundee and the medical school in particular were doing then, along with kind of LGBT Youth Scotland, to meet our accreditation awards, aside from the fact that we like doing it just because. So I'm just really going to briefly set the scene, and then Pascal's going to talk a little bit, and then I'm hoping that Mike will be joining us from Stracathra. He was doing surgery. I haven't seen him pop up just yet, but he did hope to be here as well to talk about kind of the current locality changes. So we'll keep an eye on the chat that he'll appear. When we had first arranged for this talk this year, we kind of had anticipated or thought actually we might be in a slightly different space or place to where we are now, to be quite honest. The concept behind talking today, every year LGBT plus History Month has a particular focus or theme. This actually focus and theme for 2023 is Behind the Lens, so it actually focuses in on cinema and film, but it does remind us at the end that Behind the Lens is about listening to LGBT plus people's lived experiences. So we're going to focus in on that bit because we're less film and video orientated, perhaps in some ways here. When we were kind of looking to have a guest speaker, we were very much mindful. I was mindful that at that point in time, things were very much progressing with Scottish Government in terms of reforming the Gender Recognition Act. And as we know, that had gone through Scottish Parliament. And so my colleagues that we work with and who deliver kind of dual teaching to the medical school on an annual basis for us, I was hoping they would be able to come along to provide us with really good news and to orientate us to the scene about what might be happening and changes that may occur. I'm still hopeful. We're still hopeful that those changes will happen, but as you've alluded to, Tom, and we know if we've been watching mainstream news, there has been a challenge or a difference in position from UK government overall, which is going to hold things up for the Scottish Government. So we're therefore back in a kind of holding space in order to see what might happen. And I'm certainly no legal or policy experts, but the changes if and when hopefully that they are implemented, would make things such as lowering the minimum age requirements for applicants from 18 to 16. We move away from this more medically orientated requirement for a psychiatric diagnosis and medical evidence to a system of a statute declaration or self-declaration, and then reduce the requirement for 2 years living in alignment with kind of a person's gender to 3 months, with a 3-month reflection period before an applicant and the certificate would be issued. So that's some of the changes with regards to the Gender Recognition Act as such. And part, I guess, of the reason that we would have been interested in talking about this further is that thinking about how we within kind of the medical world, and I'll probably use the royal we, as a GP, I'm slightly more orientated to general practice, but that's why Mike is going to talk to us as well. It would certainly signal an increasing change in terms of the help that our patients, my patients, may come along to us to ask, in an alignment with, there would be less requirement or need theoretically or possibly for the need to access some of the gender specific clinics, of which there are only a few within Scotland, and the waiting times from first point of referral are horrendously over the 2 to 3 years waiting time or more, though they're trying to change that a little bit. So the purpose of this was our kind of refocused or reframed talk today is really just to orientate people to how things are, what the current landscape is predominantly within NHS Tayside. If I was as a GP to be seeing my patients and kind of want to help support them on their journey, then in thinking about if we're looking at that, that ideal shared negotiation with our patients and what we might do. Many of my GP colleagues are still quite wary because they've had less training in the area, and in some ways, which Pascal will talk to in much more detail, we have to be reminded that yes, GPs are independent prescribers, but along with that effectively comes that's where the buck stops. So if we're prescribing what could appear to be or seems to be in an off-license way and are initiating blood tests, which as the person that initiates them has the responsibility to act on them, then we have to feel competent to do that. And so something along the lines of a shared care agreement would provide a bit more of a safety net and support for both GPs as well as patients. And indeed then looking at what might be ongoing referral routes or options for patients to look at if they want to have a discussion or look at choices for surgical affirmation type treatments, where are we with that in the area? So that's predominantly what we're going to focus on today. So we're not going to look at the detail, certainly myself and Pascal, we're not claiming to be, we're not experts, but it's really just that to flag to you the challenges that have been encountered to date and where we are with the aspirations to have some form of shared care agreement in place locally in Tayside. And then Mike will update us on where we are with kind of surgical options as they currently stand. So I'm going to hand over to Pascal at this point in time. Pascal, thanks. As Pascal comes online, I'll pop this slide up at the end. There are other series of activities that have happened or are happening on and around university and Nine Wells campus area over the next few weeks. So you can see some of these there, or there's a different URL code, but we'll come back to that at the end. Pascal, sorry.
Kevin, thanks very much. Please let me know if people either can't see me or can't hear me, but I'll kick off. Hello, everybody. My name is Dr. Pascal Scanlan. Well, I suppose my name is Pascal, but my title is doctor, and I'm a GP. The following 10 minutes or so will be different to the usual remit for doing this kind of presentation, but I have given it a lot of thought and consideration, and the fact that I'm doing it from my car isn't any reflection on the preparation for it. It's just I got caught up with what had a crisis this morning. Okay. So at these things also, when I watch them, there's a bit of a listing of who the presenter is, the number of papers they published, and their list of achievements. I don't have those, but I would like to explain who I am, where I am, and because it pertains to how I present this information. So I came to Dundee back in 1994 and I joined Taybank Medical Practice, and I was your standard GP, no better, no worse than anybody else for the years since. I joined the monthly meetings of what's called the Tayside General Practice Subcommittee and the General Practice Local Medical Committee. In this area, we basically do the two bits. And I used to go to those monthly, but 5 years ago, I decided to back out of some of the clinical work and become what's called an office bearer. Now, the point about that is an office bearer has some funded, dedicated time to deal with the issues that the other GPs can't deal with because they're too busy working. And that's just the best bit of it. You get dedicated. And at that stage, I had 3 or 4 things on my own personal agenda, in the sense of personal interest, shall I say, not my own personal agenda, that I wanted to make happen. I was already at that stage more than familiar with the difficulties I was facing as the GP and my colleagues were facing in providing the level of service and the level of support, all those kind of good words, to members of this community, the gender dysphoria community. I had been a GP trainer. I had gone to a particular presentation on this issue. I was moved, impressed, taken by the presentation, and the highlight of it was there was a slide went up with 16, the faces of 16 16 young people, and we were in the group asked, do we know any of them? I knew none of them, but some people there did. And I was informed that these were online influencers for this in this community. The next slide was the same 16, but X's through about half of them. Those individuals were dead, and suicide had played, from suicide. So I came out of that, giving it a lot of personal thought, brought it back to the practice, used the resources given on that day to promote that area in our own practice. But I still faced the significant difficulty that my colleagues faced. Now, going back, we're talking about 2018. So essentially in 2018, if a patient came to my practice and said, I want to register, these are the medications I'm on. I've been prescribed these medications where I used to live, which might be Lothian or somewhere over by Glasgow, Clydebank. I've moved here for reasons now. I'd like you to provide these prescriptions. And I found myself in the situation where I did not have expertise in these medicines. I had no medical legal governance to support me in this and to guide me. So I looked into it and I find to some extent unhelpful advice, but on the other hand, you could call a fair few alarm bells. So it's okay to say GPs and doctors, as prescribing doctors, should support their patients because it's in the patient's best interest. That sounds very promising. I can do this. And then you get the caveat within your clinical expertise. And then the medical defense say, well, if it's not within your clinical expertise, you're out on a limb. All right. So what are you doing here? Well, you're trying to do your best by the person in front of you. And what's on the cards? Well, your reputation, your family, your income, your future. It's not small stuff. So I found out more and then got this reaffirmed by people who know this a hell of a lot better than I do, that this was a gap in Tayside and had been a gap for a while. So I set my task that 5 years from then, this should be more than well settled. And indeed, I thought 6 months to a year would do it. So my first thing I'm actually going to do is actually apologize to the people, I apologize to the community. I failed to achieve that. I use the word fail as in failing to accomplish something, not that I'm a failure or that part of it. That goal has not been achieved. 5 years or more, 5 years since we set out to do it. Now, I didn't do this on my own. Kevin, you were part of it all the way. You know what I'm talking about. And you know the other individual GPs who brought their expertise to the table. And speaking of tables, we took it to every table we could. And that's where I'm going to go next in this presentation. None of what I say is a personal criticism of any particular person. I would like to highlight the difficulties and the impediments to making this endeavor succeed. It's particularly pertinent to this issue, but for those listening, maybe if you could keep it in mind dealing with other issues going forwards. So we kicked off by saying, well, we'll gather the information, and we did. So we knew about the need, the requirement. We gathered the data from other places that were doing it fine. So we had shared care agreements, Scottish national guidance, anything we needed, we gathered. So the forum we took it to, first of all, is the medication governance. And we went through the Area Drugs and Therapeutics Committee governance procedure. If after this, somebody wants confirmation of these things, I have them here on my laptop, well, in the car, and it's all minuted. So the first the first obstacle for NHS Tayside is, do we deal with this? Do we take this on board as an organization and engage and find a solution? And what actually happened then was, well, this seems like a national problem. So what's going on nationally? We need to engage nationally. We need guidance from other regions. So at that time, I wasn't unduly put out by this. I thought, fair enough. If that's what's needed, that's what's needed. So it went from Tayside Area Drugs and Therapeutics to the National Area Drugs and Therapeutics. And a year and a half or thereabouts later, the progress was, person reporting back who argued our case, asked for help, was that they would look at the whole issue of providing medications for a tertiary center, but they would look at the immunosuppressant drug for liver transplant first, see how that went, and then they'd look to these medications, gender dysphoria medications. So by the time we got to that level, we thought, okay, we need a different approach. I still felt, but so if you see what's going on out in the community among with my colleagues, well, some people were prescribing it and some people weren't. And they both had their reasons, and they both did what they did based on the information they had. The outcome for the people who did not prescribe started to involve MSPs, councillors. In other words, politicians started to get involved, leaning on practices to do what the patient required or needed. So the LMC deal with that. That's part of what we do. There was a whole separate issue brewing on accessing medications online and for far abroad. But my discussion today is solely about NHS patients, Scotland or Great Britain or UK, who arrive in Tayside where there still wasn't the governance to allow them to be safely acquire their medication and have the appropriate monitoring and so forth. Okay, so then the next area I thought I'd go to was, well, I think this is a risk for the organization. So it's not just a risk for the GPs. So I take it to the organizational group where the argument is heard and more meetings are arranged and time passes. So now, as regards who knows about this, well, at this stage, this is going up to the highest organization level. So this has passed, 3 medical directors have been involved in this. I think it's 1 chief exec, but definitely 3 medical directors. And it has papers and so on have been prepared, and they go to the highest level, ELT. And the feedback is, we need more information. What's everybody else doing? How much will it cost? Who needs to be involved? So you wait, and you wait, and you wait. Then, fair enough, COVID comes along, appreciate that. Tayside takes great credit for 2 major things, turning the hospital into 2 hospitals in a week, which is a phrase I've come across, fair dues. And out in the community, the GP-led part of COVID the individual there got quite rightly the Royal College of GPs Member of the Year award for the UK in respect of all that work. But we're talking here about a shared care agreement. Okay, it's not, and during that time, this work continued. I was on the Medicines Policy Group and Area Drugs and Therapeutics Committee, and other shared care agreements got written, teased out, approved, happened. These SCAs were in the interests of patients and in the interests of the GPs who operated under them and the department that created them. But still didn't have an SCA for this as we passed through 20 and into 21. Just kept pushing it. It's not that we left a year go by to say, well, any progress. Every few months, how are we doing? Who do we need? Everything we were asked for, we provided. And then last year, roughly this time last year, I thought, another promising meeting, verbal support for what should happen. And yet, the Scottish Government came out with saying, look, we could have bigger funds for this issue. And a member of the organisation started to pull this together, a proposal for funding, and multiple departments responded to that. And lo and behold, well, that's not, sorry, got to watch my, I don't mean that in a negative way, but our shared care agreement need got sucked into that process on the grounds of it was to be part of the submission for the money for pharmacy support to write the SCA and support it going forward. Now, if that was the very first start of this, I might say, well, okay, we're 6 months in, let's see where this goes. But after 4.5 years, that simply was another place where where progress failed to happen. So on a more positive note, I had another meeting with excellent colleagues not 48 hours ago to try and make this happen again. Everybody at the meeting agreed it should. I'm still, what can I say? I have to hope, yes, it will. But it is very reminiscent of other meetings I've had over the last 5 years. And time will tell, time will tell. And indeed, issues were raised that if they were raised 5 years ago, we could have got our ducks lined up, and now we're just finding out about them. So that's going to delay things. I think the desire and the belief that there should be this and that we need this is universal within the organization. But even as I said, I have failed to get this over the line in 5 years. I would say, and it's just English, that NHS Tayside has not been successful in making this happen since they became aware of it as an organization 5 years ago. And that's just the truth. It's not a complaint. It's not an attack on anybody. It's simply the truth. And so that's where we are. I could have put up slides on the 7 medicines, the 12 medicines, the preparations, how to use them, what medication, what monitoring needs to be done, where it could be done, and so forth. I don't think that would have moved this issue on in Tayside any further. I also find myself in a slightly advantageous place compared with my colleagues in that I will not be on Tayside LMC GP sub in about 3 weeks. So I finish on the 1st of March. I won't be practicing face-to-face clinical medicine and so on. In other words, I'm pretty well on my way out. So I decided to take the opportunity to pitch this in this way. And I hope I got it right. I hope that as a result of it, 6 months from now or whatever, or sooner, that this need will be met within this organization. And that's it. Kevin, I'm done. If anybody wants to ask me something, of course, I'd be only too glad to do it either here and now or by separate communication if they would prefer that.
Thank you, Pascal. You're not quite done yet, because there may well be some questions. And as you say, you've got 3 weeks with us. Can I check though? It really comes through your passion and worry and concern for this patient population, our patients. I presume someone else from LMC will be taking over that baton and will continue to work with us.
Yes, I said, oh yeah, please make, I try to make that clear at the start. This isn't I. This is we. Kevin, you're part of it. You know the other individuals concerned, and you've been engaged with them too. This will continue. It doesn't stop. As you say, somebody else will have the title, the role, and they will drive it and have been part of it as well.
I'm not certain. We certainly have time for questions, and I'm kind of keeping an eye. I've been trying to keep an eye on the emails and participants, but I don't see that Mike has appeared anywhere unless he's logged in under someone else at the moment. So I presume
I'm here now, Kevin.
Oh, you are just like the magic. Perfect. I presume that you may well have been caught up in surgery somewhere within it, but you've made it just in time. So thank you, kind of Pascal. I think there may be some questions that will come of that, but I'm going to hand over to Mike just whilst you seem to be surgery free for the now, and then we can pull out questions from kind of anyone thereafter within that. So thank you, Mike. I'll hand over to you.
I'm just going to get my presentation onto the right bit and then share. Yes, you are right, Kevin. I do apologize. I was caught up with the procedure, which turned out to be a little bit more tricky than I expected. But I'm at the point where I can hand it over to my trainee to finish it off. And it turns out, I think it's pretty good timing. Can you see my screen now?
Yeah, I can see it.
Right, perfect.
Yes, we can.
Okay, cool. Thanks. Oh, thanks for having me on. I remember I was here. I suppose I should introduce myself. I'm Mike. I'm one of the plastic surgeons in Tayside and Fife with a specialist interest in transgender surgery. And back in 2019, I gave a talk in exactly this forum to explain my vision for what Tayside could offer, which was a center for transgender surgery or gender affirmation surgery, where we would offer all the major procedures you would need: facial feminizing, chest masculinizing, chest and genital procedures to affirm the gender of our service users. So all this, what this really needed was a lot of work to try and repatriate the services that are currently contracted out to NHS England back up to Scotland, and it was also the other arm of it was the ones which were not commissioned by NSD, was to try and see if we could get them all done nationally within the centre. So that was 2019, and that was the last festival I was at before lockdown. Back then I had more hair, and I was a very optimistic locum consultant. So what happened between 2019 and now? Well, obviously the most important thing, the biggest impact for me was COVID. So that kind of gives you a rough outline with regards to what we were trying to do. Single point of referral for non-commissioned procedures for NHS Fife and Tayside, for facial feminizing, chest feminizing, revision procedures for chest masculinizing and non-binary chest masculinizing procedures. And then the bigger picture was trying to repatriate the nationally commissioned procedures to Scotland. The chest masculinizing procedures, I think the waiting list currently is somewhere about a year, genital feminizing 1 to 2 years, and then the genital masculinizing is about 8 years, the last I heard, for some of the patients. So really the idea was to bring it up here, closer to the patients with a shorter waiting list, and their aftercare would be closer to home. So in 2020, the whole focus of healthcare at that point was trying to control COVID-19 and its spread. And then in 21 to 22, it was remobilization. We were trying to deliver some form of surgical care to all our patients who we couldn't for several months. And from 2022 to, well, the next few years, it's really dealing with a massive backlog we have of all the routine procedures, because we have been managing to get through most of our urgent trauma and cancer work. Currently, there are other financial priorities, obviously. We're also possibly at risk of more financial restrictions from April onwards. And I guess there's also that huge public perception of what the NHS should prioritize with the limited resources it has in trying to clear a backlog. Are we going to essentially get hips and knees done? Why should we spend all that money and time trying to provide surgery to make someone's chest look more feminine or masculine? Or I suppose in short, what people would think would be, well, why are people having a boob job under the NHS when I really need my knee sorted out because I can't work without my knee functioning? So is that public perception that we've always had an issue with, and it's now emphasized due to our clear lack of resources now that we're trying to deal with the backlog. So disheartening as that sounds, there has been some progress between 2019 and now. So we've managed to deliver quite a lot of trans awareness training for the staff who are delivering care for transgender patients in the various hospitals in Tayside. The non-commissioned procedures in Stracathro were already delivering thyroid cartilage shaves, chest masculinizing and feminizing. In fact, one of the reasons why I was a bit late was I was doing one of those. And in 9 Wells, the aim is to deliver select cases for chest procedures where the patients are of higher risk and more complex, and they would need some inpatient care. We've not got any within the cohort right now, and I foresee that this is going to be an issue with regards to beds and how we prioritize beds. These group of patients will unfortunately be way at the bottom of the list, no matter what we think. So I'm still banging on doors, trying to remind people that there's still lots of work to be done in order to make NHS Tayside the centre for us to repatriate all these services to, and the reasons why. In fact, just yesterday, I had a text from one of my colleagues who I used to work with in Aberdeen. He now works in Malta, and he was asking me on behalf of the Maltese government, can they send patients over to have some of the genital work done? And I'm like, well, unfortunately, no, because we can't even set up our own service for our own patients just yet. So what else needs to be done? We need to set up a business plan again to justify why we need to set aside a bit of finances to deal with this group of patients and to deliver care that they, obviously deserve, as well as everyone else. We're waiting for, what I've been told is a signal from the Scottish Government that this is something that they would back. We know that the National Services in Scotland do want this in Scotland, and they continue to be on standby to help us basically put the case forward and get the contracts sorted out. And we need the chief executive to provide an indication that they agree to host the service here. So a few more hurdles. A lot of these hurdles haven't changed, but it's just more difficult due to the current climate financially. And I think that's essentially the gist of where we are. And I suppose the key message out of all of this is, yes, it's been stops and starts, but I think the key thing is to not give up and just keep banging on doors. Yeah, that's my side.
Thanks, Mike. And I think I know you were a little bit late in just because of the your surgery, which I'm sure your patient really appreciates. So I think what I'm hearing as well is there are not dissimilar parallels to where you are with kind of surgical services and the same type of stories that Pascal has been recounting in terms of kind of, if we look at the more medical management side of things. There's a couple of questions in the chat, so I'll fill these out, and then if there's any more that they may arise. So one from Nikki Conway, kind of in the absence of a shared care agreement, how are the needs of the patients currently being met in the practice where the GP doesn't feel able to prescribe these medications? Pascal, you'll, with your LMC hat on, will have a broader sense of that. In my practice, we do prescribe a bit, but it does encounter some challenges in that. Particularly, we've picked up cohorts of patients, for example, where maybe they've been students and they've come across to Dundee, where we encourage our students to register with their GP. But then, if they've been prescribed, kind of they come from perhaps they're international or European, you can't defer them back to a Scottish centre to sit in a waiting list to be seen and reviewed for an assessment that's going to be 3 or 4 more years or more within it. So we certainly have picked up on some prescriptions, particularly in relation to that, which is the kind of thing that I know Pascal maybe was alluding to. But Pascal, you're probably better placed to talk about what happens or what doesn't happen, because it's probably patchy, isn't it?
All right, well, there are different, as I said, some practices do, some practices don't. The ones who don't, they can have a conversation with the person, explain why they don't, and informally point them in the direction of practices that do. That's not a great solution, but everything we talk about, everything I say to you is a workaround. It is not the answer. So that's one. You mentioned there, and this is where it's a minefield of trouble. You can't do it for some and not for others. That's discrimination. And I mean, within the community. So you can't say, well, we have 2 patients on the medication, but we're not taking you. So you have to figure out, well, so your pool then, your numbers then start to go up. So if you say, how does at the moment, as far as I understand, across Tayside, eventually everybody gets sorted, but not without difficulty and not without distress. I didn't become a GP to sit at a table across from a politician to have to explain to them why I was not prepared to prescribe the medication that they were there pressing me to do. Again, another, I think this is important, a practice looked at everything, thought about it and said, we've been doing this for 3-4 years because you told us 3-4 years ago that you were working with NHS and there would be a shared care agreement. Enough's enough. So they linked it back and said, we haven't got the governance for the last 3-4 years. Enough's enough. We're not going to do it. They did specifically state the reason why was the lack in Tayside of this shared care agreement or the governance. The expectation was that the unit would get in touch with Tayside NHS and say, guys, where's your shared care agreement? We've got to sort this out. But that's not what happened. Instead, senior positions in the Quality and Equity Scottish government got in touch. Okay, so there are and lent on the practice, and hence through LMC we became involved, essentially saying there was, it's a veiled threat that we'll name and shame you, kind of, you shouldn't be doing this. Not what's the problem, how can we contribute to getting it fixed, but leaning on the GP. So I don't know if I've answered the question, Nicola, but eventually everybody gets sorted and each one seems to be that bit different. And remember, I'm still sticking with NHS patients here. We could do a whole other talk about the private sector, which I won't get into.
Yeah. What I would maybe wrap that around in the background, I know there are guidelines out there, and that's a lot of the work that Pascal's been talking to, alluding to. I'm just mindful of some of the audience. What I would flag is that for particularly the researchers in the audience, if you're looking for large gaps in the evidence base and ways to address or plug that, then thinking about how NHS Tayside, University of Dundee has access to and manages elements of data to look at retrospective cohorts with prescribing and comorbidity rates, then anything that helps to add to the evidence base for safety is also a welcome step to reinforce, because some of that centers in around worries about adverse risks and patient populations that it's off licensing. Just noting some of the researchers in the audience. There's another one here, Mike, probably for you, from Dr. Travers. Apologies if it's obvious. Why was the waiting list for genital masculinizing surgery much longer than it was for genital feminizing surgery? I don't know that actually. That's a really good question.
Yeah. So for genital feminizing surgery, there are, I think, about 2 or 3 different centers that provide it, whereas for genital masculinizing surgery, there's 1 center. Feminizing surgery involves just 1 stage, whereas masculinizing involves several stages. So you can see how that slowly builds into a very long waiting list. Although, to be honest, the procedures used in that center for genital masculinizing is quite outdated practice compared to what some of the units are doing around the world. But that is the only unit that's been contracted to provide the surgery. And that's unfortunately the only option the patients have.
Pascal?
Thanks. Can I just add a thought that has come to me? All the problems I've just described, this is for everybody over 16. Okay, so again, you could have a whole other meeting about, well, let's call it pediatric for individuals under 16. So, I mean, at least, we drove this part of it in the expectation if we got this bit sorted, we can then find, we'd have traction to sort the others. But just to let people know that this is even more difficult, shall we say, more problematic for younger members of the community.
Thanks, Pascal. And I can see Nikki Conway's hands up, who is a pediatrician, Nikki.
That's what made me think, Nikki. Hi, Nikki.
Hi, Pascal. Yeah, I thought I'd come in there because we do see these kids in our pediatric endocrinology clinic. In pediatrics, we've got a kind of, it's not formally agreed pathway, but there is a national pathway whereby all children and young people who identify in this way are assessed from a psychiatric point of view, and if they are then deemed to have gender dysphoria, they then can access treatments, and initially that's puberty blocking and then gender affirming hormones once they reach the age of 16. I've got a question about the Gender Recognition Act. I'm not sure, will that have any implications on the pathway in adults? Because as far as I can see, the sort of legal aspect that the GRA addresses is quite separate from the clinical one, because just because someone self-identifies doesn't necessarily meet the threshold for having a medication that in a children's case could potentially be irreversible. I'm just wondering if from an adult perspective, you guys got any thoughts on that?
Well, if I could say, and it identifies one of the core issues, this is we're general practitioners. Okay, you're talking about maybe 300 plus practitioners across Tayside who would need to raise their level of expertise on this one issue to take on the responsibility for even answering those kind of questions, Nikki. I don't know. I mean,
So presumably right now you're not initiating treatment, you're carrying on treatment that's been initiated from
some
secondary care practice. Is that the normal sort of pathway that you follow?
So no one's initiating in the sense of, well, I think that's a good idea, here you go. So that's just a non-starter. And even the issue of Tayside patients starting treatment and supporting attendance to, say, Sandyford and Chalmers, that's another thing we could talk about. Okay, so and it's separate from what I'm talking about today. So what I'm really talking about is just people who are on established treatment. Strictly speaking, it should be, when I say established, it's after 2 years. That's the guidance. They should be able to show up in any part of Scotland, get their medication and their monitoring without difficulty. And in Tayside,
yeah.
the
I
thing
would agree
with
with that. I'll just bring it back to the thing that Kevin mentioned at the start. That was all. I was wondering if that had any implications in clinical practice, or is it just a legal thing?
Well, it is clinical in that for many of the things that we do in general practice, the NHS is set up that the piece of paper or whatever it is you take to the chemist to get your medicine comes from the practice. And that's okay. So that's the way it's set up. But there's plenty of stuff where it's read on Tayside formulary. So it comes from you guys. We don't even enter into it. And then we've got the amber. And amber is the nicely ambiguous, so that if it plays well in one direction, we'll do it. But if we don't like it, we'll block it. Shared care is there to make sure that the patients don't come to harm because of this thing of getting your medication from your GP. So when you say, I'm just thinking about your word clinical, is there a clinical? So the GPs would essentially not play a clinical role in this any more than we would say for some of the other arthritis or something. We would expect the specialist who's asked us to give the potent immunosuppressive to be the one to make the clinical decisions for that patient. But we have a system whereby they can have the medication safely, they do their monitoring safely, and when issues arise, over to the specialist. GPs should not start to think, well, I've been doing this so long, I know what to do. Now, don't get me wrong, there's some level of, I picked arthritis, I'm just trying to get across what the problem is. We shouldn't really be involved in the clinical part of this. This is about everybody being sorted, covered, helped, facilitated for this narrow group within the overall group of gender dysphoria. And we don't even have that.
Thanks.
Sorry, Nikki. Thanks, buddy.
It's a potent and emotive issue, isn't it, for all of us? And I can see some of the comments as well. So thank you, Lisa, for clarifying that. I think, as I'd flagged as well at the start, I'm no policy or a legal expert, and there's a difference between what GRA's purpose is and how it's involved, which is about legality and kind of birth certificates and marriage certificates versus what we're talking about here, more so with kind of that medical lens in its own right. I don't think there are any other questions, and I'm just mindful of people's time. I always feel that it's good to have 5 minutes to think and reflect and collect before the afternoon work starts within it. I've left up here for you, just as a reminder, some other things that are happening in and around University City and Ninewells campus. So hopefully we may see some faces in and around on Ninewells again on the 24th of February, but there are other things that are happening in between, and there's some links here if you want to have a look at those. Thank you so much, Pascal, for kind of helping out and talking today, and Mike also for providing us with an update. I'm going to hand back over to Tom just to say thank you for providing us with this time and space again in February.
Well, thanks to you very much. It's our pleasure to have you, and thanks for keeping on coming back. I'm just going to share the screen of the QR code You should see it on my screen. It's inelegantly presented, but that's it. You can scan that with your mobile device right now, and it will take you to the form that you can fill in to then be able to get a certificate to say that you've been to Grand Rounds, and it will also pop up on my spreadsheet so I can see how many people come, and do feel free to leave some feedback on this system. If it's helpful to you, it's certainly helpful to us to track who comes what, where, and when. So,
Tom,
hello?
sorry, Tom, how long will it be? Every week it goes out on the primary care newsletter with the link. Scott sees to that. So will this one be up, and how long will it be available for my, for primary care colleagues to click on and watch?
The video or the QR code?
The recording of this.
So I edit this and then it goes onto YouTube. I hope I'm on call this afternoon, so it might not get done today, but it'll be done by the weekend.
Yeah, that's grand. So it'll be up next. It'll be on Tuesday when it goes out to people to say, it's available. Every Tuesday we get our newsletter, and this one will be there in case people ask me. Yeah, thanks, Tom.
On the channel. So there's your QR code. Do click on that, get your certificate. It comes very quickly within a couple of minutes. All right then. So I'm seeing if I can find next week's the program. I think next week it's Rory McCrimmon, Dean of the Medical School, who's going to give us the annual review of the medical school and how the university has progressed over the last little while. So that's next week, the university's year in review. You can go onto YouTube and see all Grand Rounds past. I've been updating them slowly. If you go on there, please do comment, like, and subscribe. Tick the wee bell for notifications, and then you'll see get a notification of the Grand Rounds as I upload them as we go along. I think our most popular has now had 1,300 views, and there's a few more that are just creeping up to 1,000. So we do get plenty of views, and they are from all over the world. So thank you if you're watching. If you'd like a slot at Grand Rounds, then please get in touch. We have spaces from May onwards. So please do get in touch if you want to give a talk. Thank you very much to our three speakers. Thanks to everyone else for coming and hanging on till the end. And I will see you all next week.
Bye.